Welcome to CleanMedKE, where we make clinical medicine and surgery clear, structured, and clinical. Today, we are diving into antiarrhythmic drugs clinical blueprint, taking you from cellular physiology to bedside application. Medical disclaimer. This presentation is for educational purposes only and does not substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or qualified health provider. To understand these drugs, we first have to understand the targets. On the left, we see nodal cells, like the SA and AV nodes. They have slow action potentials, characterized by intrinsic automaticity, thanks to the phase 4 funny current and T-type calcium channels. On the right are non-nodal cells, the workhorses of the atria and ventricles. These have a fast AP that requires an external stimulus to fire, featuring a rapid phase 0 sodium influx and a distinct phase 2 plateau. Why do arrhythmias happen? It usually comes down to 3 pillars. First, enhanced automaticity, where pacemaker cells fire too rapidly. Second, triggered activity, where abnormal ion leakages create premature beats, known as EADs or DADs. Third, and most common in clinical practice, are re-entrant circuits, where electrical signals loop continuously through anatomical or functional pathways, as seen in atrial fibrillation or WPW. Management strategy: rate versus rhythm. When managing tachyarrhythmia, we have 2 main strategies. Rate control targets the gateway, the AV node, to block conduction from the atria to the ventricles using beta blockers, calcium channel blockers, or digoxin. Rhythm control targets the heart tissue itself to suppress ectopic foci or break re-entrant circuits using sodium or potassium channel blockers to restore a normal sinus rhythm. The classic way we organize these drugs is the Vaughan Williams system. Class 1 blocks sodium channels, Class 2 are beta blockers, Class 3 block potassium channels, and Class 4 block calcium channels. We also have a Class 5 for miscellaneous agents, like adenosine and digoxin, that work through unclassified mechanisms. Class 2, beta blockers. For beta blockers, remember the rule of 4s. Beta is 4 letters, they target the SA and AV nodes, 4 letters, and they act on phase 4 of the slow action potential. By decreasing CAMP and pKa, they delay the phase 4 slope, slowing the heart rate. Key drugs include metoprolol and the ultra-short-acting esmolol. Be wary of ADRs like bradycardia, asthma exacerbations, and masking hypoglycemia in diabetics. Class 4, calcium channel blockers. Next is the rule of 7. Calcium is 7 letters, and these drugs affect phases 0, 3, and 4, which sum to 7. Non-dihydropyridines like verapamil and diltiazem block L-type calcium channels in nodal tissue to slow the heart. A critical clinical pearl. These are absolutely contraindicated in decompensated heart failure because they are negative inotropes. Class 5, adenosine and digoxin. In Class 5, adenosine is our reset button for acute SVT. It hyperpolarizes the cell to stop the heart momentarily. When administering it, warn your patient they may experience a frightening sense of impending doom or coronary steal syndrome. Digoxin is unique. It inhibits the NAK ATPase, which ultimately increases intracellular calcium for better contractility, while also increasing vagal tone to slow the AV node. While it is a go-to for rate control in patients with both AFib and heart failure, you must monitor electrolytes closely, as digoxin toxicity risk is significantly worsened by hypokalemia. Class 1, the salty CAB driver. Moving to rhythm control, Class 1 sodium blockers are categorized by the mnemonic the salty CAB driver. Salty stands for sodium, and CAB tells you the order of phase 0 blockade strength. 1C is the strongest, followed by 1A, then 1B. Class 1C, flecainide and propafenone. Think fries, please, for 1C drugs like flecainide. These are pure, potent sodium blockers used as a pill in the pocket for paroxysmal AFib. However, there is a critical warning. They are absolutely contraindicated post-MI or in any ischemic heart disease because they are highly pro-arrhythmic in damaged tissue. Class 1A: disopyramide, quinidine, procainamide. For 1A, think double quarter pounder. These offer moderate sodium blockade, but also minor potassium blockade, which lengthens the action potential duration. This makes them useful for WPW, but increases the risk of QT prolongation and torsades. Watch out for specific toxins, synchonism with quinidine and drug-induced lupus with procainamide. Class 1B: lidocaine and mexiletine. Finally, for 1B, think with lettuce, or B for best post-MI. These are weak sodium blockers that uniquely target ischemic, depolarized tissue. Unlike the others, they shorten the action potential duration. They are a first-line choice for post-MI ventricular arrhythmias, but monitor for CNS toxicity, like seizures or altered mental status. Class 3: potassium channel blockers. Class 3 drugs, remembered by the acronym AIDS, amiodarone, ibutylide, dofetilide, sotalol, cause a massive delay in potassium repolarization. This drastically increases the effective refractory period, helping with cardioversion and rhythm control. The trade-off is a high risk of QT prolongation and torsades de pointes. Amiodarone is the outlier. It actually has mechanisms from all 4 classes. While it rarely causes torsades despite QT prolongation, it has a massive side effect profile due to its long half-life and iodine content. You must monitor for pulmonary fibrosis, thyroid dysfunction, hepatotoxicity, and blue-gray skin discoloration. The tox screen summary. Let's recap high-yield adverse reactions. Remember quinidine for synchonism, procainamide for lupus, lidocaine for CNS toxicity, adenosine for that frightening sense of impending doom, and beta blockers for masking the symptoms of hypoglycemia. Putting it all together, let's look at torsades. The cause is usually Class 1A or Class 3 drugs blocking potassium efflux, which prolongs the action potential duration. On the EKG, this shows as a prolonged QT interval that transitions into a lethal twisting of the points. The cure is first-line IV magnesium sulfate, discontinuing the offending agent and increasing the heart rate to shorten the action potential. That concludes our clinical blueprint for antiarrhythmic drugs. If this guide helped clarify cardiac pharmacology for you, help us demystify medicine for others. Please like, share, and subscribe to CleanMedKE for more high-yield, structured clinical reviews. Clear, structured, clinical.